Hi, everybody. Thank you guys so much for joining us and being a part of this project. We are so excited to be partnering with CIs, alumni, people who are interested in trying something new, and probably some of these things you guys are already doing. You know, as on the academic side, we are as interested as in how you guys are doing things and how we can support that. And hopefully to create an environment where these new clinicians can actually come in and feel like, though this is a new environment, it's the clinic environment, it's still a familiar environment in which they can develop their clinical reasoning and develop under your tutelage, under your expertise, that they can continue to grow. And so I'm very excited actually to have all of you as part of this experience. So in this next half an hour or so, what I want to do is actually just have a conversation with you and outline a little bit about how we have used these clinical practice guidelines, these ICF categories, as a way to create a foundational thought, a foundational rehab concept that we can build on every week. So every week of ortho, we use the same rehab concepts. And it would be beautiful if those same rehab concepts in some way are the similar kinds of language and thought processes that our CIs are also having, of which I believe in already that is occurring. But I think these types of conversations are really two ways. It will be very interesting for me to hear your feedback related to the shortcomings of the language or the benefits of the language. I do use these ICF categories when I mentor residents and fellows in China, which I'm headed to Sunday for a month. So I've been doing this as well and found it to be very useful. So just as a heads up, this webinar is being recorded for those who couldn't attend, and then I will forward this webinar back to you and to all of you so that you can, if you need to review it or pass it on to one of your colleagues, that will be fine as well. Just checking in. You guys can all hear me, is that correct? Can you all hear me? And please, you can hear me. Okay, and please feel free to chat. Throw in some questions. I'm just watching the chat on a different screen. What's up, Brad? Great to see you. So, okay, so why the guidelines? So, I remember when I went to school. This is year 2000, I graduated in 2000, and really I was kind of at the mercy of any particular thought process or school of thought that my instructor came from or that my CIs came from, and many times that would take me for a loop. I would have to relearn all of these new ways at viewing the world, even though many times they were quite similar. So at the entry level, most of us in the faculty have all adopted the guidelines as this foundational language because there is value in being somewhat homogeneous in the way that we teach the students to see the world. So I hope that this becomes a kind of springboard to it's a common place for the students to be able to interact with the CIs and for the CIs to then layer on their individual expertises, their individual ways of seeing the world. I think this is the whole reason why they have CIs, is because they can expand their world. So one of the things that the guidelines helps with, I think, is it creates a basic expectation of what should occur in the examination, because we are trying to get students to not just do everything that they know, and also to match the interventions, evidence-based interventions, to the impairments that they found. So this guideline-based rehab concepts can create this foundational way of thinking that allows us to have reasonable expectations. And I think it can really be a stepping stone to helping the students develop these basic pattern recognition habits. So when I'm mentoring in the clinic, after every subjective exam, I ask the student, or I ask the resident actually, so what category do you think this person fits? So I'm beginning to get a sense of whether they can begin to match this patient to a pattern, and based on their hypothesis, it allows me then to watch as they do their exam and do their treatment, whether they're actually doing what they're thinking. So again, I think the guidelines can be a platform that allows you, the expert clinician, to expand the student's worldview without completely changing it. You can build on it. You can expand it. So that's why actually I want to take a moment to just share how we're using the guidelines in the classroom, of which many of you who are alumni have experienced this in some form. So when the guidelines came out, it was actually quite a revolutionary experience for me as well as for my teaching. So by the time we integrated the guidelines into our class, we would use these basic rehab concepts. Day one, in the first day of class, I would teach them about what it means to see someone with a mobility deficit and what it means to examine that and to treat it and to reassess mobility and to see if the patient's functional limitation or their disability is improving. So these are foundational concepts that at every class, I ask the students, hey, what are some of the common pathologies of the shoulder or of the knee that you know or you've seen before? And as they list all of these pathologies, we start trying to connect these pathologies to the ICF category. So students will be like, oh, I've seen ACL tears. Oh, what do you think? Do you think when the ligament's torn that the joint might be a little bit unstable? What category do you think that fits? Oh, movement coordination impairments. Got it. They've connected it. They know what that means. They know what the expectation of is in general of how to manage these people. And they'll MCL sprains, ankle sprains, they understand that the very similar rehab concept actually is applied to managing these patients. So we revisit these rehab concepts every week, every new body region. All those common pathologies that we are talking about in the clinic, they are associated to these ICF categories. And then, as many of you fondly remember, the mock evals, the mentored evals are built around these very categories. We are just teaching the students at a very basic level. These are the basic building blocks of how to treat people who are stiff, how to identify them and evaluate them appropriately, and then to treat them to reduce their stiffness. So really, from the building blocks, right, from this very black and white environment that we create for the students, so the foundational part of learning, we need to be able to pass them on to you guys in the clinic, and you will kind of ramp them up and help them deal with this world that isn't as black and white. But I still think that there's value in trying to, as best as possible, classify the patient. So the clinical instructors are really the magic sauce, I think. And we hope that from the entry level, what you guys see here, you end up turning these guys into something like this. So really the clinical environment and the educational environment really walk hand in hand with this ultimate goal that we create these great young clinicians who are happy and qualified and can do a good job in serving their patients. I think that's what all of us desire. So I've chosen these four main categories. I'm just going to show a few pictures, and after each category, I'd love to have just a quick chat to get your thoughts on, does that category fit? Are there holes in the category? Are there reservations about the category? So let me start with mobility deficits. Something as simple as the guy comes in and says, my knee's killing me, and when you watch him walk, you note that he doesn't have enough extension. He may not have enough flexion either. We don't know yet, but he looks like a guy who might have some arthritis. I think Chris, you might recognize this crazy guy. Of course, Dan is my wingman in ortho now, and you'll see that there are many of the clinical practice guidelines built around mobility deficits. We're pretty good at mobbing stiff things. In general, I tell the students, you're going to have patients, and they're going to be complaining about pain or things they can't do in life because they don't have enough range of motion. So if they don't have enough range of motion, naturally it would seem appropriate to assess their active and passive range, to assess accessory mobility, and any other structure that could limit range of motion. And the natural then intervention, and this language, the key findings and interventions are the same language that you'll see in the apps that I'll just give you a quick glimpse of before we hit the Thursday session. So the interventions then naturally is, hey, you're stiff. You're not happy about the things you can do in life because you don't have enough range. I'm going to do things with manual therapy to restore your mobility. I'm going to do things, therapeutic exercises that improve the mobility that you need to function. And because this particular category often fits things like osteoarthritis, post-immobilization stiffness, we encourage them to remain active and also to do things with weight control. So the guidelines would generally support that. So some other common conditions, like I said, once they learn about back pain or knee pain with mobility deficits, we apply the same idea to all of these common conditions: spinal arthritis, facet joint syndrome, hip and knee OA, post-immobilization stiffness. It could be a wrist after a splint or a fracture, post-immobilization. It could be elbow fracture or ACL after the ACL repaired. They are now in the splint and they've lost some range of motion, or ankle sprain. And frozen shoulder. So these are some of the common conditions. So actually, let me just take 1 second here to open it up and just to get any feedback or comments related to this particular category. And if you want to speak in, please just go ahead and unmute yourself if you have any comments about having students classify these types of patients as mobility deficits, or the challenge of doing that.
Hey, Dr. Wong, Joe Klein talking.
Hey, Joe.
So are you looking, I know, anyways, basically, are you wanting them to go as far as looking at a knee, or if you think it's a meniscus, are you still concerned about diagnosing them as like a movement coordination deficit, or are you looking more specifically to get them to pinpoint that meniscus? What would you guys prefer from that standpoint?
Well, I think they have to, they have to know that, this guy planted, twisted, and his knee's
Right.
clicking. So they should be able to do the appropriate special test
Right.
to rule in or rule out the meniscus. And they should also be able to decide, is this really an instability problem, or is this a mobility deficit problem? They're going to have to make that call as the eval reveals information. So I still think it's important for them to have that language. I mean, the physicians and other PTs, they're all going to be talking about meniscus. But
Right.
ultimately, the problem, if you think about, if I said, what do you think this problem is? Oh, it's a meniscal problem. In reality, there's no particular pathway for rehab or treatment with just that particular pathological classification.
Correct, yeah.
Yeah, so I think it's valuable at that point to say, okay, I wonder, let's take a look at what you're going to do for your exam. So many of our students will say, oh, you know what? Before I do my eval, I look at the script and I kind of start planning it, and I kind of look through the app and I'll go, oh yeah, those are a couple special tests I want to do. I want to assess range. Muscle power, maybe secondary, but still valuable. So they're going to start assessing. And the cool thing is, at the end of the eval, it's valuable to say, so now what do you think it is? I think this guy is primarily a mobility issue. Great. So what are you going to do? Oh, I've classified as mobility. I'm going to treat mobility and see how this turns out. That is how all of this works to the better of the student and allows us to actually have some reasonable expectations.
Okay, sounds good.
Yeah, so perfect. Great question. So I hope that the student would be able to, you're ultimately going to force them to classify the patient based on the key biggest impairments that are tied to the functional limitation and see if they can match a reasonable treatment and Therax. I think that is how we should do this kind of pattern-based management, so that they can actually find success in doing the right thing, and they eventually can reproduce that and get faster and better at this pattern recognition. So, great. Please jump in and type in a chat if there's any other questions, and then we'll just stop at any point. This is movement coordination impairments. So this category, though it's named a little bit weird, movement coordination impairments, it technically covers the sprains, strains, and instabilities, the whole spectrum. That's why it's a little bit weird. But the general idea of it is that the injury occurs to the tissue because the joint has moved too far out of neutral. So now surrounding structures, capsule, ligament, muscles, all of these tissues are now affected because the joint has moved too far beyond its neutral boundaries or its safe boundaries. So you can see that this applies to lumbar sprain strains. It can apply to ankle sprains. It can be a one-time traumatic injury. It can be just the way that this guy lifts all day long, right? So the way that people move and the postures that they hang out in can eventually create pain and disability. So when you think about that, and I show a picture here of whiplash as well, right? The tissues have moved too far out of neutral, and now any number of structures, really if you think about sprains and strains and whiplash or a wrist sprain, the reality is that who knows what structure is injured there? Facet joints, interspinous ligaments, supraspinous ligaments, discal tissue, probably all of the above. So when you think about these key findings, the patients may have pain or a sense of instability or pain when they move out of neutral, right? So you might observe postures or movements like excessive flexion, excessive adduction, internal rotation, excessive external rotation during their functional movement. So this guy has an ulnar collateral ligament problem. And typically the pain or the apprehension gets worse as you get towards end range where you're actually going to stress that structure, right? So our students will go, oh, okay, so when people move wrong repetitively, and those movements may excessively stress these structures, or if they moved excessively in this one-time trauma, these patients have developed some injury to some tissue. Oftentimes in the testing expectation, there is some kind of provocation or stress to the joint or the strained ligament or labrum that you will expect them to do. So if someone has an unstable shoulder, it's a movement coordination impairment, shoulder pain with movement coordination impairment. They're moving too much out of neutral. I expect to see some of these labral tests and some of these instability tests. Same thing for the knee, a varus or valgus stress test or a prone instability test. The other key findings that are commonly associated with these problems are mobility deficits in surrounding regions, right? Areas that they can't move that is now causing them to move in the injured area too much. So there's value oftentimes in its assessing the region, the adjacent regions. So I think that's valuable too, so that the pattern that the student is thinking about is not so focused, so narrow. And I'll be interested in your thoughts about this as well. The students often will have this big confirmation bias issue. They're like, I know the pattern, I'm on the pattern, it's got to be this pattern. I think that is really where, again, your clinical expertise helps them to see the world in a little bit broader way. The guidelines also talks about how in this particular classification, there's often some type of motor control problem, particularly of the deep stabilizing muscles. So your abdominals, your deep neck flexors. And so the expectation then is for this category. So if any of my residents say, I think this is a movement coordination impairment, he probably hurt himself by bending too much, excessive lumbar flexion. We do expect to see some type of lower abdominal movement test to see if when their spine begins to give or move excessively, or the deep neck flexors, where do they begin to show an inability to hit their target pressure. This is just a standard part of what we would expect. Students who think this category is present, what we'd expect to see. And then from the intervention perspective, the guidelines would say that generally, if they're very acute, it's okay to temporarily brace them. And we see that in all the sprains and strains, really, that the tissues can heal and they don't have to be stressed. They're not in danger of being overstressed again by temporarily using an external brace and putting the tissue near neutral, right? Because the injury occurred because they were out of neutral. So this is quite common. And then there should be some form of motor control training, and usually that involves teaching the person to have a more optimal posture, teaching the spine to be closer to neutral or the shoulder to be closer to neutral, and then doing motor control training, whether that is, PICR, motor control training, internal external rotation, or deep neck flexor training. That is an expectation of this particular category, that there is some strengthening and control training of the muscles that help to stabilize or control that tissue in neutral. And of course, if you find impairments of the mobility in the surrounding regions, then your standard, whatever you need to improve mobility in those surrounding regions so you can spread the stress of those functional movements over multiple joints, then these would be fair game. So again, a regional interdependence kind of model. And then actually the most recent guidelines actually talks about using movement re-education to prevent recurrence. So after the patient is now less irritable, they can actually start doing some bending or some step downs. This is a really important time to train them on how to move in better ways. So for this category in particular, some type of functional movement re-education would be great for you as the CI to go, you know what? A lot of what he does is stepping up and down. And you noted that you saw this movement fault. Well, he's ready to be trained. How are you going to do that? And again, a lot of these training videos, right, the observation of the fault and the correction of the fault, they're all inside the app. And actually, you can add in your expertise as well. I like to do this when I train people to reduce their adduction internal rotation. So I think this is where your expertise, again, kind of augments all the basic stuff we put into the app. In no way is the app a comprehensive, exhaustive library of all of these things. They're really just the basic bare bones stuff that we wanted to put in that we think you can springboard off of. So some other common conditions related to these sprains and strains: lumbar sprain strain, UCL sprain or tear, whiplash, shoulder instability or labral tears, functional, these are ACL, MCL, all of these ligament tears in the knee, ankle sprains, wrist sprains. All of these injuries typically occur because the tissues went too far out of neutral. So generally, I expect if the patient has a really acute knee sprain, that the students are going to calm down the inflammation, give them a brace or help them get a brace, and slowly allow that tissue to calm down, then slowly restore the mobility, get the strength up again, and then move them up this rehab pyramid that we'll talk about, working on balance and power, and then higher level functional activities. So actually, let me stop for a second here and open it up to the team. Any thoughts, comments about this particular category and whether it can be used to cover a lot of these conditions or any concerns related to it? Okay. Let's see. Doesn't look like anybody has any major comments or concerns related to it. Okay, so I'm going to keep moving. Feel free again. This is the sprain strain category, the people who move too much and often move in ways with postures and preferences in ways that are perhaps stressing structures that are resulting in pain. So that is the movement coordination. So usually we would name this as like a shoulder pain and movement coordination impairments, or shoulder stability and movement coordination impairments. If you look at the guidelines, they will call it here ankle stability and movement coordination impairments, the ankle ligament sprains, knee stability and movement coordination impairments. So students will often just say, hey, this is probably ankle pain and movement coordination impairments. I think this guy's moving too much. Great. Let's see. Are you going to do a ligamentous stress test? Are you going to measure their range of motion and demonstrate that there's excessive range? Are you going to stabilize them near the middle to allow the tissues to calm down, right? And so you can begin to get some prediction, some expectation of what you want to see. Okay, so let me move on to the next category. So this is the radiating pain category. Again, this category generally fits patients who are complaining of nerve-related pain. Now, this doesn't have to be spinal nerve root. It can be any peripheral nerve. It can be any nerve, because the idea of management is relatively similar. So you can see that in general, these radiating pain categories are built into the low back pain and neck pain categories, or neck pain guidelines. And in this 2017 decision tree that you'll see that I sent you, over here on the far right, you see that they have defined this group based on some common symptoms, some common exam findings that I'll mention in the next couple of slides. So they said usually we see patients who are having shooting pain down their arm, a narrow band of lancinating pain. It could be down the leg, it could be into the carpal tunnel region, and they may have upper extremity dermatomal paresthesias, myotomal changes, numbness, which means that our expectation of the student, of the clinician, is, I'm curious if you have any ideas of where this nerve might be entrapped. So there should be some common entrapment site assessments. Is it at the neck? Is it at the cubital tunnel? Is it at the carpal tunnel? So an expectation that they're looking and provoking or decompressing at some of these entrapment sites. So for the neck pain guidelines, it'd say we'd expect you to do Sperling's and distraction test and see if you can influence that pain. I'm basically checking that entrapment site. We'd also expect the students to do a neuro screen, right? So all of you guys are in some form probably doing this or making a very clear choice not to, because but I think for now it's valuable. If it's a nerve problem, it's valuable to get the students to do their neuro screen and to perhaps give them a baseline to assess for progressive neurologic deficit. So you can see their standard neuro screen and some form of neurodynamic assessment. So the moment my resident says, hey, I think this is a radiating pain problem, I already have an expectation to see this, entrapment site assessment, neuro screen, and some neurodynamic assessment, of which they are careful enough. They know what the irritability is. They know how to put the patient and slowly take up the tissue tension. I think it's also really valuable to add the movement component into this. So I am listening and watching for the clinician, the student, to recognize certain movements or postures that may compress or strain the nerve. Because when you think about the intervention should really tie into teaching them movements or postures to avoid that allow the nervous tissue to calm down. So you can see here observation of the posture and correction. Here he's looking at rotation, cervical spine rotation. Is it less than 60 degrees? And in general, the guidelines would suggest that you should teach the patient to avoid postures and movements that compress or strain the nerve, right? So give the tissue some time to calm down. This can include things like shoulder girdle unloading, right? Unloading the shoulder girdle so that the nervous system has a chance to breathe. And then working on the entrapment sites. So your manual therapy, whether that's side glides to the neck to open the foramina, or some type of soft tissue to the arcata froche, or, wherever the entrapment is, the carpal tunnel. And then intermittent traction or manual therapy to those entrapment sites would be indicated, as well as then some type of targeted intervention to the nerve, which usually is your neurodynamic mobilizations. And it would be great. I think consistent with how you guys are practicing on the highly irritable people, we try to have pain-free nerve sliders. In the patients who are more chronic, they can handle going to end range a little bit, then to move into tensioners or more slump-based type treatments. So here is the other radiating pain conditions, cubital tunnel, the piriformis syndrome, carpal tunnel, spinal stenosis, plantar nerve entrapment. So you can see that all of these have some entrapment site or some movements that may cause strain or compression on the nerve. So avoiding those movements, educating the patient. Then you can do some entrapment site reduction. So working with manual therapy, and then adding some nerve mobility. So Again, once the students classify this as radiating pain, you should already know to expect. You know what to see and expect. Okay, so let me take a second here and open it up for any comments, actually. And make sure you unmute yourself if you have a comment to make. I see Brian was able to join us. I'm curious, does this classification, will the concepts of this classification work well enough for you to utilize and ask the students to classify the patient, and for you to know or have some expectation of what things that you would expect to see? Any comments from the CIs?
No, I mean, I think it's good as it narrows the train of thought down. I mean, I know that was something that was difficult for myself. This is Joe talking again.
Yeah, hey Joe.
Just as far as making things more streamlined, I think it's a good thing, and then you can run with it from there. If you've identified it as a motor planning or more motor coordination deficit, move from there. You know,
yeah.
It gives them, and if they're wrong, then they can progress from there. So
perfect. Okay. Yeah, I think the other thing that I would mention too is that many of these patterns, these classifications, patients will eventually transition from one to the other. So you may go, you know what, this guy was a spinal stenosis guy, so I'm treating the radiating pain, but eventually the radiating pain is getting better, and now he's just a mobility deficit of his low back, so I'm just going to keep treating that. Yep. So I think that is a great way to be able to say, hey, you know, actually it's actually very common that most of these patients are probably have some movement coordination impairment underlying it, but you may not be able to get to training their movement until you take care of some of their primary impairments first.
Right.
Right. Perfect, Joe. Any other comments? Okay, perfect. Here is our last main category. So this is the muscle power deficits category. So Achilles tendonitis is the main guidelines that they have for this, but really the idea of how to manage this, it covers a lot of the tendinopathies. So if you think about the key findings from the guidelines, it's really pain with activation, pain with palpation, some possible changes in tendon size or the collagenous structure, so we know that to be the tendinopathy side of it. And oftentimes I think the students, besides just looking at the source tissue, right, the value of doing a subjective is, I wonder what kind of things you do that are causing this tendon to be overused or to be inflamed or to have these changes. So a recognition of the movements or activities that overuse the tendon, and maybe the ways that they move that might not be optimal, like, you know, a quad dominant squat, and the way they jump, maybe that's what's contributing to the patellar tendinosis. Because it's a muscle power issue, the patient will say, hey, you know what, I'm having a hard time lifting my arm. Okay, that sounds like a muscle power thing to me, but it also could be a frozen shoulder mobility deficit problem. So the student's going to have to tease that out. That's fine. That's important. That's why they're clinicians and not technicians. So a decreased ability to generate force. So I can't lift my arm. It kind of hurts. A shoulder impingement would kind of fit this because the tendon's involved. And we would expect that assessment of range of motion, the guidelines about the Achilles tendon problem suggest that range of motion assessment is important. Are some of these tissues overly short and need to be lengthened? That's one of the possibilities. The interventions, because most of these conditions are considered overuse problems, there should be some education about what are some of the activities that you shouldn't do. These tissues need a little space to rest. And then the guidelines also talked about stretching seems to help in some cases. Manual therapy, it's generic. Like, we're not trying to make any particular cookbook. Besides, at least we're going to narrow the scope of the things that the guidelines and the evidence seems to suggest is beneficial. So yeah, you could do your instrumented soft tissue mob for manual therapy. You can improve the stiffness of the gastroc with your manual therapy. The interesting thing too is, I would say, that in many of these like superficial tissue problems, patellar tendinosis, Achilles tendinosis, your ankle sprain, superficial tissues, they seem to respond reasonably well to low-level laser and ionophoresis. So it's not uncommon for these types of modalities to make it into the guidelines, which I think is kind of interesting. And then taping, we commonly use taping, reduce this patient's symptoms. I think it's good for patients to have less of this, symptoms related to their pain. Sorry, I'm getting a little bit of echo from somebody. If you don't mind just muting your phone or your computer, and then when you have questions, you can jump back in anytime. And then here's one of the key things. We know that with most tendinopathies, that isometrics, concentrics, or eccentrics, something to do to reload the tendon and create reorganization. I think that's how you get people better over the long term. So first you have to calm things down. Then you should modify the way they move a little so they don't continue to stress the structures. And you can use whatever you want here to reduce the patient's symptoms. And then at some point, some type of tendon reloading is essential. And so here are some of the other common conditions: patellar tendinosis, tennis elbow, de Quervain's tenosynovitis. We apply the same rule. Rest the tissue, calm it down, gently restore the range of motion, because much of the time you may be using some type of splint, so they might become slightly mobility deficits. And then slowly restore the tissue length and start gently reloading the tendon. And I generally suggest using isometrics first and then into your concentrics and eccentrics, because we know that isometrics seems to have like a pain analgesic effect, much similar to manipulations. So posterior tib tendinosis. Okay, so that is the 4 main categories. That covers people with tendon problems, overuse, impingement. I mean, these are very basic patterns. They won't cover everything, and some problems are more complicated. I think a shoulder impingement, yes, you could call that a tendinopathy, a rotator cuff tendinopathy, but in reality, the skill of treating that patient has a lot to do with movement analysis, muscle strength of a lot of the scapular muscles, capsular mobility deficits, scapular faults and motor control. So I think it gets more complicated. The students are ready for that. I think we've trained them for that. And it will be great to have you guiding them through as they're trying to do these things on the patients. But these are the 4 main big categories that you can see cover a lot of the common conditions that we're going to see. Before I open it up for a quick discussion, here are 4 categories that I haven't talked about because they're a little bit more specific. The back pain with related leg pain category is really a specific category related to pain referred from the disc. So the guidelines doesn't really think of this related leg pain problem as a nerve problem, a neurogenic problem. Typically, these guys get better they centralize with repeated movements. They peripheralize if you go in the wrong direction. So it's very Mackenzie style repeated movements. And the reason why I say we believe that this is actually pain referred from the disc is because if you think about repeated extension movements, if this was really a radicular problem, a nerve problem, repeated extensions would not make your leg pain better, right? It would compress the nerve root. It closes down on the foramina. But if this guy's leg pain is disappearing, you are likely just changing the structure of the disc or changing where the inflammation is in the disc, and that is reducing the leg pain. So the differential diagnosis for this condition is actually a negative straight leg raise and positive findings with centralization procedures, like repeated movements. And you'll see all of that inside the app. So let me just take 1 second to show you what I mean by that. So you can see that most of you I've set up your passwords. I've set up your passwords at PhysioU. So when you log into PhysioU, you will see that there is a sign-in. And once you sign in, and you guys, I think, have been given the email or where to get the app for your mobile device, for your phone or your tablet. So if you look at low back pain, Here is a quick access panel to all the diagnoses. Here you can actually just go by pain pattern. So if we went by pain pattern, we could choose something like this. Back pain that's diffuse and achy in the whole leg. So they have some hypotheses. This could be a disc-referred leg pain, acute low back pain and related lower extremity pain, or it could be a nerve problem. All right, great. So you have some red flags here. When you look at this condition, in the physical exam, you can see that the key findings for this particular group, this person, is some repeated movement exam. And if they can't handle being in weight bearing, they may go into a pain limited repeated movement exam. So gravity minimized, right, in prone. And if you look at the differential diagnosis, you'll see that there should be a lower quarter neurologic assessment. We would expect this to be negative. And a straight leg raise, we'd expect that to be negative. Great, so it's not a nerve problem. The guidelines does say that these problems can coexist. So surely you can have disc disease where the nerve root's irritated and there's referred pain from the disc. There's no denying that we see that in the clinic all the time. But it is helpful to define those as two separate problems. Any comments about that? You can also see in the differential that we've asked the students to do their quick screen, which could be a deep squat, it could be active range of motion and overpressures or thoracic quadrant with some PAs to clear the spine. So generally for quick clears, we've asked the students to generally overpress the joint. If they're not very irritable, take them into quadrant and overpress it and then do some PAs, particularly for the spine. All right, so let me finish off. We are now at 12:43. So let me just finish off by saying that neck pain with headaches is in the guidelines. And this is tied into cervicogenic headache problem. Much tied to upper cervical dysfunction as well as deep neck flexor changes or impairments. Then you have your plantar fasciitis group, your heel pain guidelines, and then your labral tears, your non-arthritic hip pain. So those are all common guideline patterns, but they are not as interchangeable across the different joints, so I haven't spent as much time here. So in closing, any comments or thoughts about trying to get the students to use this language and holding them accountable to this language? Any thoughts or challenges with that from your perspective as CIs? And make sure you guys unmute yourselves if you're trying to speak.
This is Chris.
Hey, Chris.
I think it's a good framework to start with, and I just got to get into the app and just kind of see what's there.
Yep.
And kind of with the students with it.
Okay, great. Now, anybody else? Good comment. So I'm curious, as CIs, and you guys, as being part of the project, are already showing yourselves to be people who want to be involved, who want to be engaged. How often are the students connecting with you as they go throughout their day? Let's say if they have 3 evals a day, what is your typical expectation of the engagement of them with you?
This is Joe again.
Yep.
For me, definitely student specific. Some like immediate feedback afterwards, some like feedback during.
Yeah.
Some students I have go in, just get the main subjective, and I'll have them say I'll step out and I'll maybe give them, give me their, is it a motor planning problem? Is it a mobility deficit? What do you think? And go with it with your objective.
Nice.
Others, I'll do a quick feedback at the end. Some don't like to be cut off, and they like to go through their whole thing on their own. So I think it kind of
depends.
I've definitely used this a lot myself with other students, just as far as this type of classification.
Great.
Just because it explains it better to the patient. I think the patients have a hard time. You get told so many things at different doctors, at different specialists, and you tell them, hey, you're stiff. I can help you with that.
Yes,
I think
beautiful.
That's an easy way to transition to. From our understanding, where we can use all these fancy terms and technology, but to relate it to the patient, I think is huge.
That's awesome.
So,
anybody else? That's great. And when you tie into this patient education thing, I would just say that every single one of these different patterns, so let's see, lumbar, leg pain, here's the interventions. Every single one of these patterns does have a patient education component. So here's what's going on in layman's terms. Something in your back might be causing some of your leg pain. How long will it take to get better? This is probably what we're going to do in physical therapy. You might have direction-specific exercises or mechanical traction possibly. And here's what you can do to help yourself. And all of the patient perspectives from JSPT are linked here. So you can actually go, you know what? Don't worry about the MRI that your doctor told you about your disc problem, because here's something that you can read. So all of those are linked in the app. And soon we will have a different app that will actually allow you to email that to the patient quite quickly. So we're almost done finishing that app, and it's a patient education app. You can see it here. So all of the common problems for head and neck or lumbar, they're all here. There's a basic patient education piece that they can read. They can read or listen to. And it's like this generic written for patients type of article. And also all the JSPT patient perspectives are here, and you can just send it as an email to the patient, or they can scan it with their phone on the QR code and they can read it on their own. So that will be part of this PhysioU stuff that you guys have. We just haven't quite released it yet. We're in beta for it. So the last thing I would say is that we use this particular priority system to help students figure out what to do first. And I think that would be useful to be unified among all of us. This is from Claire Frank and from her book. We always say that if pain and inflammation is present, you should take care of that first. And that may involve some postural changes, improving the posture. And as that improves, then we go to restoring range of motion and muscle length. Then we go to muscle power and muscle function. Then balance and gait, and then functional movement. So I think it's useful to ask the student, so you have found all these impairments. What do you think we should start with today? And always redirect them to the same pyramid of fundamental priorities. I think that's useful. That will be very useful, especially if we're uniform with that. And then as a clinician, as a clinical specialist, you can then nuance them. You can say, yeah, but in this particular case, I would actually train them how to move so that their inflammation can go down. So there might be things like that. I want to thank you for being a part of the bridge. I hope that these guidelines the language of the guidelines can become part of this bridge. And on Thursday, tomorrow, at the same time, we'll have another this one will be a little bit shorter, the top 10 things that mentors and CIs can use the app for, and some suggestions on how that might go in the clinic. So I just want to say thank you to each of you for what you do, for being a part of this amazing experience for the students and being willing to be a part of this. So I am free. I know all of you probably have patience, but I'm happy to stay on and chat with anybody who wants to chat. So thank you guys for taking the time. I know it's very busy for you guys, but we're really thankful for what you do. And please let me know if you did not get a login for your PhysioU apps. All right, thank you guys.
Thank you.
Yeah, absolutely. Are there any questions? What's up, Chris? I see you on there. How you doing?
Good, no question.
Okay.
I gotta just go to the app and check things out.
Awesome. Okay.
Hey, Dr. Wong.
Hey, Brad. How you doing?
Doing good. How are you?
I'm good, man.
I like the app so far.
Awesome. I think you guys will find a lot of it's very familiar. A lot of the stuff, the same way we think, is all kind of built in there. So I think you guys are a perfect group to be able to help guide the students, or you'll know where they're coming from, really.
For sure. A question I had was, are you still kind of gearing towards movement system impairments and classifying them by directional based?
Yeah, so that's a good question. When you look at the app, you'll see that we have used a language that is essentially more clear, instead of just saying, oh, this is a flexion syndrome, which could mean any number of things to any number of people. Let's say lumbar disc disorder. The movement fault associated with this problem, you'll see, is potentially flexion rotation.
Sure.
So excessive lumbar flexion is the way we're naming it, because lumbar flexion syndrome is just too generic. It can be confusing.
Gotcha. Okay, that makes sense.
Yeah. So all the tests really are built around Shirley's movement test, right? So
Right.
when we're asking the students, like, hey, what are you going to do with this guy that you think has excessive lumbar flexion? We ask them to choose one or two tests in different positions that we think their irritability will allow. So if they can't handle being in weight bearing, then do something in quadruped and sitting, or quadruped and supine, and see if you can observe the movement fault and correct the movement fault.
Okay.
Because since the movement coordination training is part of how you want to reduce the recurrence, then you do want to do some type of movement assessment and then movement correction. But because this guy perhaps is a related leg pain, right? He's having pain down his legs. Even before you go here, you might have already chosen to treat the key findings, the key impairments, which is whatever I need to do to get rid of your leg pain. You know?
Yeah, gotcha.
And then over time, you do the movement corrections. So,
Okay.
Great question. Thanks. Great comment. And Brad, I would be very interested in, and you as well, Brian and Nikki, whoever's still on, as you guys are thinking about what are some great ways to utilize this in the clinic with the students. I would love to hear that. I only have so much of a glimpse, and I do this with the residents, but I think the students come in at a different level. Certainly different CIs have different styles. So I would love to get your input on how you think the app, or this language and the app, how it can enhance the communication between the student and the clinician. So I don't know if you have anything off the top of your head.
I had a student from Regis University.
Uh-huh.
And they kind of they had very different classifications on some of this. And so I think this would have been really helpful to show her, to kind of see how I think and I classify pathologies.
Yeah.
Because I think they looked at it very much more, oh, this is just flexion, let's treat that, versus narrowing down.
Yeah.
So I think people that, haven't had this background of learning it and getting this solidified this way, I think this will be really helpful to narrow down thinking and make it more clear.
Yeah.
And just see if it,
I think
for students in the future.
Yeah, I think one of the reasons why we built it was so that what is kind of floating around in your conversation can actually be down on paper. You can actually talk about it. You can look at it. You can discuss it. You can say, in our classification, we would have just called this guy excessive flexion, and we're going to treat him by going into extension, But in reality, the guidelines would say, well, this guy actually benefits from repeated movements in a specific direction, and there's some theory behind why that person has leg pain that can be useful to help the patient to understand things, like Joe had mentioned, related to patient education. So I think that all of this really, my hope, and correct me if this doesn't make any sense to do, my hope is that if possible, on a daily basis, at least one of the patients that the student is seeing, that they can have a conversation with the CI, kind of let their thoughts out, reflect, right, and share about some of the decisions that they made. Maybe talk about it with the app, with the CI, because I don't expect all the CIs to know everything all of the things that the CIs know are probably in the app, but how it's organized may take a little work for people to kind of figure out. So I almost feel like it's better to have the student reach out to the clinician, use the app as a sounding board, and then allow the clinician's expertise to then kind of mold and shape, the pattern. So that's kind of my dream of how I think it can be used on a regular basis in the clinic. Like the students use it, they have their own ways of using the app. They'll use it before the eval. They'll use it after the eval to check if they did something wrong or right, or where should they go next. But I think in terms of the clinician CI interaction with the student, my dream is that at least once per day, to squeeze out a little bit of time to actually reflect on one of the patients that they had, to kind of talk it through, use the app as a way to connect, and then you as the CI would go, oh yeah, that's right on. You are right on pattern. Now, can you see how when you did this, the patient got better? And so the next time, your progression, what would you do for your progression? What would you do next? So that's my thought on how it can be used. And again, I'm curious of your thoughts, either Nikki or Brad. Is that useful? Is that hoping for too much? Or what do you think?
I think it will be just another way to clarify their reasoning.
Yeah.
Kind of looking retrospectively and saying, here's what you did in your evaluation, and either clarifying you were on two different train of thoughts, and then going back and saying, oh, this is where you started, and then you kind of took a U-turn, as sometimes happens. And so this is where you could have think about this for next time. And maybe having it done, looking back on this and going retrospective, would be, I think, helpful.
Okay. And
I know I do a lot of my feedback at the end of the day.
Yeah.
Just because time-wise.
Yeah, you're so busy. Everybody's busy. Yeah.
So I usually go back and at the end of the day, going through and kind of going through each eval. I feel like that kind of works the best, and so it'll probably be nice retrospectively for me.
Okay,
going back.
Perfect. Yeah, and I think the students will use it on the front end, and it can be a conversation piece on the back end, And I also think sometimes it'll be useful because student will say, "Oh, well, this is how I was taught to do it," and then you can say, "Well, let's look at the app and see how you were taught to do it." And so there's at least some way to hold them accountable to something, So I think that might be useful as well.
Sure.
Awesome.
All right. Well, thanks, Mike.
Hey, thanks,
good
Brad. Yeah, good to talk with you. Hey, Nikki, we'll be in touch. Thank you for being part of the team, and I'll see you guys hopefully Thursday for a short session.
All right. Sounds good. Thanks, Dr.
Okay,
Wong.
bye.
Bye.